Thank you, Mary, and welcome to all of you who braved getting up here. And I know it's a celebration in this city, and yet it's also still very sad for what's gone on. So we do want to note both of those. But it's the National Education Alliance for Borderline Personality Disorders' pleasure to be co-hosting this conference. And when Mary called me to tell me about it, and of course doing a first conference is quite a feat. You get better at it as you go along because you understand where the glitches come in. But when Mary told me about it, I said, well, is there any way we can help? Because we have done a lot of conferences, actually probably about 50 now. And when Mary said that she'd like us to join them, that was an incredible honor for us because Mary was one of the first people to speak at one of our first conferences. So for us to come together, and this is how the field grows, but is by collaborations and partnerships, it's a pleasure to be here today, Mary. So thank you, and thank you for being so brave to make sure this conference went on. As I told Mary, I got an email from my husband. I was driving yesterday, and he said, where are you? Because he wasn't sure I was going. And I said, well, we're driving, and we're in the car. And he said, I always thought Mary Zanarini was a genius. So now I emailed him this morning, and I said, I guess she is, because the conference is on, and so here we are today with wonderful speakers and presenters. I also want to invite you to come to our website, which is easy to remember. It's borderlinepersonalitydisorder.com, and also encourage you to take one of our bracelets that we've left here because next month is BPD Awareness Month as designated by Congress. So the more of you that recognize that and help build awareness on this disorder, the more we can advance the agenda and help people impacted by this disorder. So thank you. Now it's my pleasure, and this is really such an honor also for me, to introduce Dr. Charlie Swenson. I could say a lot about Charlie, but I guess for me what I'll say is he's such a deep personal friend in the sense that he was the one who brought DBT to the East Coast, and I had the good fortune to be on his unit where he was the unit chief. So today to have Charlie here and presenting on DBT, in Boston, I guess it's about 20, 25 years later, Charlie, right? Since you brought DBT to the East Coast. But this is Mr. DBT. Marcia might be Miss DBT. This is or Dr. DBT, I guess is what we say. So I'm gonna have Charlie come up and perhaps say a little more about his background because it's quite long and I wouldn't want to miss anything he'd like you all to know about him. So Charlie.
Guy in the back went to great trouble to mic me up, and now I just took it apart. Thank you, Perry, and thank you, Mary. It's a privilege for me to be the leadoff hitter. Now I got to remember to turn it on. To be the leadoff hitter at this. I have to say, 24 hours ago, I thought, this is crazy that we're going to do this. My kids said, Dad, you're not going to go to Boston, are you? And my wife said, you're going to Boston? And, so I held back, Mary, though I didn't send you one email. I just plagued Perry. And then figured out, let's go with it. Let's go with it. Let's go with it. Must have been how you thought. So it's brilliant that we're having it, even with probably a smaller number than would have been. But it's the first one, and we got it started. And I get to start, so I want to tell you just a couple minutes about myself because really the main point of having me on the agenda first is that I'm one of 4 people that's going to interview a person with borderline personality disorder to demonstrate a model of treatment so that you all get to see that and think about that. So I don't want to do anything much more than that. But just a brief intro. Yes, I was basically, when I went to New York Hospital in White Plains, New York in 1982 to direct the long-term psychotherapy inpatient program for Otto Kernberg. And I had been in psychoanalytic training in New Haven. And so that was my model, and I did that for several years at New York Hospital. And then actually Marcia Linehan's first publication was 1986. In the Bulletin of the Menninger Clinic, not a research publication, but just a little announcement. It was very interesting in a psychoanalytic journal. And I got interested I heard from Alan Francis a little more about it. I went out to Seattle. I watched Marcia. I talked to Marcia. Those days, nobody knew Marcia, so I could have all of her time. She just thought it was so great that a doctor from Cornell on the East Coast was interested in her little treatment. So what a privilege for me to get to suck all of that up and watch her and think about it and notice the pluses and minuses in relation to the model that was going on where I worked and that I had learned. So I was first trained, I guess, in what is these days called transference-focused psychotherapy. And around that time, I ran in the Boston Marathon, to tell you the truth. Right about, just about that time that I was there doing that model, and before I started DBT. So it's pretty emotional to come back here, and was emotional to watch what happened. I went on and have done DBT since then in a variety of ways, and so I'm privileged to be able to be a demonstrator of DBT today. Anything else I just wanted to? Okay, so to introduce what I'm planning on doing is I want you to understand that I'm making the assumption that most of you are familiar with DBT. I don't think you'd be here and not be at all familiar with it, so I'm not going to teach DBT. I think instead what this is a chance to demonstrate it for a half an hour in an interview, the practice of DBT, so that after that I can make a few remarks about how the interview went and what I thought as the essence of DBT in that interview, and then to really have time for you guys to raise questions with me about why did I do this, why did I do that, how did I think about this, how did I think about that. So I think I want to engage you in thinking about DBT in a sort of a hands-on way. That's my thought about it. Now, I was sent a vignette about the patient in advance. All four of us who are doing this throughout the conference were sent a vignette. So I know a little bit of history that you don't know. And in order to think about how to engage you in a DBT learning experience, I realized I don't want to just do the initial consultation as if I've never met the patient I'm evaluating, because that would not be as distinctive to DBT. It would have distinctive elements. It would have the behavioral, really, emphasis. And a lot of factors. A behavioral assessment is different than a psychoanalytic assessment or an assessment for mentalization-based therapy, et cetera. But instead, it's not as distinctive as the first session in therapy after somebody's agreed or is considering being in it. So actually, I'm going to do that. So I want to give you brief history so you know a little about what I might know after the intake. This person's initials are KG, actually, which made me think this is Kevin Garnett from the Boston Celtics, but it isn't. This is a young woman whose name is Katie. And Katie is 24, and she comes from a family in the area where she has twin sisters that are 22 and a brother who's 21. She has a father who's a financial advisor and a mother who has been a stay-at-home mom. And she's, since she was a little kid, she sort of had a hyper-temperament that included taking the form of hypersexuality, which was considered somewhat inappropriate by parents of kids that she played with. She went on into adolescence, and when she was about 14, she started cutting herself, and also the beginning of an eating disorder. And during high school, she had a soulmate boyfriend, and when they broke up, she made her first suicide attempt through cutting, and she was hospitalized at that point. And by cutting her wrists the way she did, it ended her career, her very promising career, her passionate career as a gymnast. And she didn't have the strength in her wrists anymore to really compete at that level. So it was a real heartbreak in many ways. She went on into college, and actually more problems developed. I mean, her self-harming behaviors became worse. She started using a lot of alcohol. She still had her eating disorder. She was emotionally dysregulated a lot of the time. She would get very attached to, her pattern had already been to get very attached to a man or a boyfriend and then really rely on that person excessively to the point where she had trouble functioning without her college boyfriend that she met when she was a freshman. And in the course of that, as I learned in the intake, after a few months of that, when he went away for a weekend to go home, and she texted and called him and he wasn't responding, she then issued a suicide threat or an announcement on his cell phone to let him know that she was going to take an overdose and kill herself, and that it would be on his hands because he made her do it. And then she basically, I didn't have much history after that, except that she went on in the last 3-4 years to have a lot of self-harming behaviors, a number of treatments that apparently never worked out to really make changes, and she went on to continue with some of the other problem behaviors, in particular her eating disorder. So now she was referred to me out of another hospitalization after another self-harming attempt. Apparently the self-harming behaviors are really now the primary, biggest problem going on. There hasn't been a suicidal event for a while, though there's chronic suicidal ideation. So that's her story, and she's referred to me as a possible candidate for a DBT treatment and a DBT program. And I've already got that intake. She knows I've gotten that intake, and now she's going to sit down with me to begin therapy.